Okay. Well, in the interest of everyone's time, I think we're going to go ahead and get started. And I just wanted to go over a few housekeeping items before we do. Again, my name is Chad Sievers. Help kind of coordinate these webinars. A few housekeeping items, though. During the presentation, please mute yourself by pressing *6. If at any time you have difficulties hearing our presenter, just unmute yourself and let us know. You can also use the chat feature, which is found on the right side of your screen. And if you have a question during the webinar, you can also use that feature too, and we'll try to answer questions as they come up. We'll have a question and answer session at the end of this webinar. And this is just a reminder that the webinar is being recorded, and we'll provide a link to the presentation from our website. So without any further ado, I'm going to turn this over to our presenter, Dr. Karen Worley. Remember just to click these arrows to get to the slide.
Well, happy Good Friday to everyone. I'm not accustomed to doing webinars, so it feels a little awkward not to see your faces. But please write in your questions or your comments, and as I go through this material, I'll respond to it. I'm going to be talking about children with sexual behavior problems today, and I want to really emphasize that that's what these kids are, children with sexual behavior problems, not perps, not offenders, but children who've had some sexual acting out, and that's a real important concept to keep in mind as we work with this population. Objectives of what we're going to talk about. First of all, I'm going to talk about kind of a brief overview of childhood sexuality and what are considered healthy behaviors versus not so healthy behaviors or concerning behaviors, talking about the kids in a way that puts them more in a context of being kids and not some mysterious alien being, talking about safety planning as a very foundational response to a sexual behavior problem, and also providing support for the parents of these kids. Okay. First of all, there are a number of myths about kids who have sexual behavior problems. The first one is that if a child has been sexually abused, they're going to go on to molest. And so then the reverse is, if a child has a sexual behavior problem, then they must have been abused. And those are not necessarily, they're not accurate statements. And the vast majority of kids who've been sexually abused do not go on to molest. If there's an assumption that a child who's acting out sexually has been exposed to sex in some way, and there are a number of stressors that can contribute to that kind of behavior. We'll talk about that more this afternoon. Also, the assumption that if a child is engaging in sexual behavior, they must have a very serious problem and need intensive intervention. And a lot of these kids do not need that level of intervention. Another assumption or myth is that it's the parents' fault, that there's a lot of assumption that somehow parents have created a problem for their kids. And certainly in many cases, there are things parents can do, and going forward they can manage kids better. But in many cases, these are happy, healthy families, and parents are doing the best they can. And finally, there's a myth, there must be something wrong with a child to engage in sexual behavior. And there are a lot of kids who engage in sexual behavior and for much more normal, developmentally expected kinds of things. Okay. In early sexual development, kids do all kinds of things. In fact, prenatally, little boys have erections. Little girls have vaginal lubrication. So the sexual feelings are there before a child is even born. So the behaviors they engage in can be from normal, keeping a hand in a diaper when or touching themselves when a diaper is being changed, and would be very normal and appropriate kind of behavior, to things that are very worrisome, intrusive, perhaps aggressive in getting a peer or a younger child to go along with some sexual activity. Most of the sexual behavior that children engage in is private. They have learned that this needs to be a private activity. And so adults don't know what's going on. And we hear lots and lots of parents saying, oh, they're not doing anything sexual, they're not aware of anything sexual. Well, adults just aren't aware of it. And so their early sexual knowledge comes from peers if adults aren't giving them basic information about names for body parts, how we take care of our bodies, how we keep our bodies safe. If parents assume that children are too young to know this, and they assume that even when sometimes when a child is 10, 11, 12 years old even, which is pretty old, then these children are getting this information from their peers, which is not very high-quality information. Kids make value judgments about early sexual experiences based on what they're learning from their peers. And so, obviously, they're going to benefit from a positive guidance on these matters from their caregivers. In young children, behaviors that you might expect might be the reproduction conversations that kids have, which is basically, where do babies come from? And there are a lot of funny stories about where kids think babies come from. Usually this is between peers or siblings. It's a common activity for kids to play, I'll show you mine if you'll show me yours. Very common in early school age. Playing doctor.
Is that good one? Yes. You'll have to. Well, we can try that one. Sure.
So you might want, whoever, I'm hearing some background noise. It might be helpful if you would check to see if your phone is muted. Playing doctor, there are different kinds of doctor games. You can have pediatrician versus gynecologist, and so you might be more concerned about the gynecologist OBGYN game. But those are within the range of normal behavior. Sometimes kids masturbate and without penetration. They might play kissing or flirting games, and sometimes kids will use dirty words or dirty jokes that they're learning from their peers, and that might be within the normal range of behavior. Okay. The American Academy of Pediatrics has published information about sexual behaviors in children regarding 2 to 6-year-olds. Again, normal, common behaviors, we've just been over those. It's important to note that with the touching, the genitals, showing genitals to peers, it's children who are toilet training are just absolutely fascinated with going to the bathroom with whoever's going. So trying to look at adults going to the bathroom or seeing people nude. The thing that's important to remember about these behaviors is that they're transient. They don't persist, and if kids are redirected, they don't keep coming back. And it doesn't happen a lot, and kids are just as likely to engage in more age-appropriate behaviors as this. What would be less common would be if a child was rubbing a body part against others. And I've had little children, when they were talking about their abuse, come up and hunch me on my knee, and I had to redirect that. So that's one example. Touching a peer or an adult on their genitals would be less common. Maybe mimicking some sexual acts. These behaviors might be occasional, but it disrupts others. It's uncomfortable to others. People get concerned. But these behaviors can be transient, and kids can be distracted from them. Okay. A much more uncommon behavior would be asking an adult to engage in a sex act, or asking a peer to engage in a sex act, inserting objects into their genitals, touching an animal's genitals. That's a behavior that very often families won't report unless they're asked about it. Either they're uncomfortable or they don't think to tell about that. Explicit imitation of sexual intercourse. That might include sounds and very intrusive kinds of behaviors. These behaviors are often very disruptive or persistent and resistant to distraction. And then the most concerning behaviors, or rarely normal behaviors, would be sexual activity between children who are of significantly different ages, either according to 4 years or developmentally. They're in different developmental phases. If these sexual behaviors occur frequently, if there's emotional or physical pain as a result of this, the other child is really complaining about it, unhappy about it, if there's any use of coercion or physically aggressive behaviors in this activity. And when I say coercion for children, coercion doesn't have to mean that they were held down and forced. It can be social coercion, threats of I won't be your friend anymore, I won't let you play my video games, those kinds of things. Those can be very important to young children. The behaviors are persistent and they need immediate attention. Here's another set of norms for children's sexual behavior, those that were described by Ileana Gill. And she looks at the fact that from 0 to 4, children have limited peer contact. So most of their sexual behaviors are touching oneself. The peer activity, you would just expect looking and pointing, maybe touching, but it would not be a particularly advanced interaction. Ages 5 to 7, you're going to see increased peer contact, and that's when you see a lot of the playing doctor or playing girlfriend and boyfriend occurring. And then 8 to 12, you see there's increased contact, and you see more experimental sexual interaction. Okay. If childhood play is typical, then the children know each other well. If a child has just met another child for the first time and is convincing them that they need to engage with sexual behavior with him or her, then there's something concerning there. I'm thinking right now of a child we worked with who just went down to the park in the neighborhood and met other little boys that were a few years younger than him playing basketball. And so the very first time he met those children, he convinced them to go behind a dumpster with him, and he engaged them in sexual activity. That would be very concerning. He didn't know those boys. If children are about the same age and size, again, on a similar developmental level, that's where you expect the peer group to be, and so normal behaviors, it would include that age range. If it's spontaneous and unplanned, if it doesn't happen very often, if the children don't feel coerced into it, it's a voluntary activity. In fact, it should be a fun activity. They're doing it because they're curious, they want to, they're not upset by it. They may become upset if an adult finds out about it, walks in on it, and they may be very embarrassed at that point. And typical behaviors would also be easily redirected. If you tell a child, you know, touching yourself, your private parts, that's a private activity and you ought to do that in your room or your bathroom, a child learns that easily. They're not engaging in sexual interaction with peers, say, in the family room in front of the TV while they're they easily learn that this is the kind of behavior that parents expect their kids not to do. Okay. A problem sexual behavior, again, would be beyond the child's developmental stage. It might involve, or it would involve threats, force, or aggression. It doesn't have to be physical aggression. It can be a psychological threat for a child. And remember, think of it from a child's size. I won't be your friend is a very significant threat to another child in some situations. It involves children of different ages or abilities. Kids may be the same age and the same size, but one may be much more intelligent than the other and able to manipulate the other child into sexual activity. And also, problem sexual behavior might provoke strong emotional reactions in one or the other or both children. And so a child is very angry or anxious as a result of the behavior. Okay. I find the Child Sexual Behavior Inventory by Bill Friedrich to be really helpful. He did a lot of research in the 90s and early 2000s. One of the outcomes among non-abused 2 to 12-year-olds was some very common behaviors that children engage in. They're shy with men, boys play with girl toys, girls play with boy toys, they walk around their house in their underwear, they scratch their crotch. All of this is within, the majority of kids do this. On the other hand, a very, very rare behaviors among a non-abused sample, the most rare was putting mouth on sex parts. So oral sexual contact among non-abused children was very rare, and so that should send up a red flag as a rare behavior. Doesn't prove that a child's been abused, but it's something that bears looking into. Asking another to engage in sex acts or masturbating with an object, all of those behaviors occurred at a rate of less than 1%. You know, I mentioned the fact that there's sometimes an assumption if a child engages in this behavior that they've been sexually abused, and certainly that's one hypothesis that needs to be considered. But there are a number of other variables that are related to sexual behavior problems. Family stressors, families having lots of stress are more frequently found with kids who have problem sexual behaviors. Family dynamics, child neglect and maltreatment. We frequently see domestic violence in families where a child's having a concerning sexual behavior problems. Another situation would be new siblings. The birth of a mom's pregnancy and then the birth of a new sibling creates a lot of questions about where babies come from and sexual behavior for kids, and that might lend itself to some sexual exploration. Family nudity may be very stimulating for some kids. Exposure to live sex acts or pornography, and we're certainly seeing lots and lots of kids exposed to pornography these days because it's so available. For some families, just primetime television can be very stimulating for kids, or soap operas can be very stimulating for kids. Chaotic family life, a lack of structure there, a lack of boundaries in the family, lack of parental communication about developmentally appropriate behaviors. And again, sexual abuse can be a cause of sexual behavior problems. Okay. Barbara Bonner and her colleagues have done some research, a lot of research, some of the better research on children with sexual behavior problems, and she came up with a typology of that's not related to personality or character styles. There have been a lot of efforts, or there have been some efforts among researchers to find certain personality types that tend to have certain kinds of sexual behavior problems. And Barbara says, no, it's not related to that. There's just, the evidence just isn't there. One type is sexually inappropriate behavior, where there's inappropriate behavior but no contact. That might include sexual talk, flashing, that kind of thing. Sexually intrusive children might engage in inappropriate sexual contact, but only briefly, kind of a drive-by flasher or toucher, so to speak. And, of course, the most concerning behavior would be from sexually aggressive children who would engage in prolonged contact and that would result in oral sex, vaginal sex, or anal penetration, maybe mutual masturbation, other kinds of more extensive sexual behaviors. And in most cases, these would be either implicitly or explicitly coercive or aggressive. Okay. So when do you intervene? Because some of these behaviors aren't as concerning. It would be important to intervene if the parents have tried to stop it, have corrected it, and it continues. Anything that involves penetration would be concerning. That would be more advanced behavior than you would expect in a preschool or prepubescent child. Doll play that includes explicit sexual activity. In young children, their play with toys can be a rehearsal for other behaviors, and so that would need to be intervened with, especially when it involves any kind of penetration. Sexual contact with animals. Sexual behaviors occurring between children of different ages or developmental levels. Another time for intervention would be if the child's been abused or exposed to sexual activity, and now they're engaging in inappropriate sexual behavior. If the sexual behavior has an intervention, parents find out, they redirect the child, and it goes underground, and it becomes apparent that it's continuing to occur, but the child is managing to keep it secret, whether they're secretly engaging other children or other kinds of activities. Another would be masturbating frequently and to the extent that they're having redness and they're hurting themselves. Okay. So, if you're going to have to intervene as a therapist, the first step is a good clinical evaluation. And I warn people again and again and again, get as much information as you can prior to the assessment. If this is a referral from the Division of Children and Family Services where there are concerns as a result of a finding of underage juvenile aggressor, it's really helpful to get the investigative report. DHS has a report on CRIS that's called Report to Prosecuting Attorneys, and they will provide that to therapists. So if you can get that before the assessment, it really gives a therapist a good idea of what they're going to be looking at. Because if a family's coming in, they're referred by DHS for a sexual behavior problem, and they get to you, and they can give you a vastly different description than what was initially reported. I'm thinking of a family we've worked with where it was a young boy who looked very physically immature. And his mother was very disturbed that he had been referred by DHS for services to address his sexual behavior problem with a peer who was several years younger, because they were physically the same size, and she felt like he'd been very unfairly treated and described the problem as just a one-time incident of curiosity, and he's being pilloried in the press, so to speak. And, you know, if you looked at this boy and you listened to the mother and you think, they just did this one time and they're the same size and they play together all the time, you would agree, what is the concern? But in fact, the other child had reported multiple incidents with physical force. The other child was highly traumatized. So that gave a different light and allowed the therapist to be able to explore different types of information during the initial assessment. The people who need to participate in the evaluation would include the parents or the legal guardian. If there's a DHS caseworker that referred them, they would likely need to be there, and of course the child who is reported to have had the sexual behavior problem. I know it's a problem sometimes when we get a child who's in DHS custody. We'll get a transportation worker brings that child with no knowledge of the child's current behavior, how they're doing in the foster home, even what the referral's about. And you can't do a proper assessment if you don't have, caregivers involved with this child for your assessment. So as you move on into the parent interview, it's, you want a full family and child history, including family dynamics, history of maltreatment, family stressors, cultural, religious values related towards sexuality. It's not uncommon to find out that there's a history of sexual abuse for one or both of the parents, and that when their child is engaged in this behavior, it's very disturbing to them. And sometimes the treatment will need to be more addressed to getting the parents calmed down about what may be kind of normal behaviors that are very concerning to the parents. Family stressors, going through divorce. Sometimes families have lots of boyfriends. A mom may have lots of boyfriends in and out. Those kinds of things. Those are going to be contributing factors to the child's stress as well, and maybe exposure to sexualized conversations or behaviors. Cultural or religious values. We have to be very respectful of people's cultural and religious values, but sometimes it's important to note that these values may create a charged environment or a difficulty with parents talking to children about sexual matters, just like names of body parts, that it's okay to, touch yourself, to clean yourself, that kind of thing. So being respectful, but also exploring these issues and how it impacts the child. Look at family strengths, the home structure, boundaries, environment. If a lot of people are living in the same home, if the family is homeless, you're going to have a lot different issue than in a family that's got lots of space. One family that I worked with some time ago, the father was an over-the-road trucker, and he would take the whole family on his trips for his work. And the parents would get back up in that bed behind the seats in the truck, and they'd have sex back there, and the kids were sitting in the front of the truck. And that was extremely overstimulating to those children, and they engaged in a lot of sexualized behaviors that brought them to the attention of authorities. So that would be poor boundaries for those parents who thought that, since they were not in the same bed together, it was all right to do that. Behavioral history for the children, are they impulsive, are they aggressive, other kinds of behavioral issues for the kids, and the family attitudes toward treatment. Sometimes parents are very interested in getting involved and getting their child's behavior where they're not so concerned about it. Others are very resistant, anxious about it, secretive. And so all of that is part of the assessment process. And finally, parent attitudes towards the safety plan. We're going to talk about safety planning more in a little bit. The interview with the child is not an investigation. It's not a forensic interview. So it's important, well, as in any kind of interview with a child, you've got to develop the rapport. You've got to talk about what confidentiality is going to be. Obviously, if a child is going to hurt themselves or someone else, that has to be reported to parents or caregivers. Some therapists are very careful about saying, what you tell me is going to be confidential. But I also tell children, there may be some things that you tell me that I think we need to talk to your mom about. And so, I'll tell you that I'm going to talk to your mom about it. Or there may be things that you tell me about that I don't think are private to you unless you tell me. So if something really needs to be private, please tell me so I'll be sure if I think it's okay to not mention that to your mom. Usually very young children are not concerned about parents knowing what they talk about in a session. If they are concerned about that, that's important information and needs to be explored. The interview with the child, you get baseline information on their behaviors, their knowledge of appropriate boundaries, if they know about touching rules, that kind of thing. And then I hope you've discovered through doing your TFCBT that testing can be very helpful and inform your treatment plan and your treatment. The instruments that I find very helpful in working with children with sexual behavior problems are a general behavior inventory. We use the BASC, the Behavioral Assessment Scale for Children, which gives the parent report on, it reports on general behaviors. For older kids, I think it's teens, they can fill it out, but we're talking about younger children. And then we use the Child Sexual Behavior Inventory by Bill Friedrich. That's really helpful. That assessment tool is very sensitive to the motivation of the person filling out the test. So if you have a step-parent who wants that nasty little kid out of their house, you will find a score that would make you think the kid was Jack the Ripper. So you've got to take that into account. Or if you have a parent or caregiver who really doesn't see this as a problem and doesn't want people prying into their business, that child, they may not report even the minimal behaviors that you would expect in a child. So taking that into account, that inventory gives parents a list of behaviors that they might have not have thought to report and that the therapist was not likely to ask about, but with that list in front of them, the parents can report these behaviors that occurred within the previous 6 months. Okay. So you've got your assessment done, and you're beginning to work with the family. The first thing you do there is the safety plan. The safety plan is a plan of supervision for the child that is intended to keep the child and other children safe. The safety plan needs to be victim-centered, meaning if another child has been hurt by by the sexual behavior of that problem, that child, to the extent possible, doesn't need to be reharmed by being removed from the home or having to deal with very difficult circumstances because of issues related to the child with a sexual behavior problem. I'm being kind of vague there. We frequently see children who are victims moved in with relatives. You tell that child, you didn't do anything wrong, but they're moved out of the home because it's difficult to place a child with a sexual behavior problem. So that moving on with the safety planning, it's important to include conditions that you identify in the assessment process. Perhaps what's identified in the assessment process is there are no doors on the doorways in the home, and children are being exposed to adult sexual activity and hearing it at night because there's no door. Well, part of the safety plan would be finding a way to get doors up in that home. If the child with a sexual behavior problem is sleeping in the bed with the child that they engage in sexual activity, having a separate room and separate beds, that kind of thing. Schools and other settings may need to be involved if the child is having trouble getting their behavior under control, if they've engaged in inappropriate sexual behavior at school, and so staff may need to be involved in a plan of supervision in that setting. And for kids who are court-ordered into this treatment, the safety plan should be incorporated into the formal orders or the DHS the DHS case plan, and we have it in our treatment plan. Okay. The safety plan is to protect the victim, the child victim, who may be in the same home or not, to protect other children who could be engaged in this activity, other vulnerable children, and to protect the child with the sexual behavior problem. If you have a young child who's engaging in some intrusive or concerning sexual behaviors, they're putting other children at risk, but they're also putting themselves at risk. If they direct those behaviors at an adult or an older child who doesn't have their best interest at heart, it may put that child at very strong risk of being sexually abused themselves. A safety plan also protects a child with a sexual behavior problem from the appearance of risk. If there's a lot of family turmoil around the offense and people are angry at the family and the child who committed the offense, even though the parents say he's not going to do this anymore, well, what would happen if Aunt so-and-so knew he was playing in the yard without you watching with other little kids? What could they say? And if you were out there watching, what could you say? So the fact that the child was supervised is going to protect that child from possible allegations in the context of a difficult situation. Okay. The safety plan, when there's a concerning sexual behavior, needs to begin immediately, and it's ongoing. It may change over time. It may be gradual. It will eventually loosen up. If there's a new behavior or a new concern, then it might need to tighten up. Those who can supervise a child who has a concerning sexual behavior problem would include responsible adults aware of the child's history. You can't send a child down the street and let your neighbor who has a bunch of little kids keep an eye on him. I mean, she may send them all in to take a shower together, or she may send this child in to help a younger one go to the bathroom. So those would be violations of a safety plan and put that child at risk for engaging in other inappropriate sexual behaviors. Now, it's not always appropriate for teachers or other people in where the child is involved in daycare to know the details of why a child's being supervised like that, but certainly in a less formal setting such as a home or the neighborhood, parents, anybody that's going to have supervision of that child needs to know what the safety plan is. The safety plan might include restrictions on contacts with other children. If a kid has an extreme issue with their sexual acting out, they may not be able to be around other children for a while. That's pretty rare, but it does happen. It may restrict activities, activities that are going to be unstructured or unsupervised. Those may not be appropriate for a child until his or her behavior is well under control. There should be guidelines for privacy and dressing and using the bathroom in the home. Lots of families run around in their underwear or walk around nude in their homes, and I'm not here to judge any of that, but if you have a child who's been overstimulated sexually, it's not a good idea to do that and to set very clear boundaries. So when people are outside of their bedrooms, they need to have their clothes on. If they're using the restroom, the door needs to be closed. If they're using the restroom, nobody needs to be in the restroom with that child unless it's a parent who's helping them. That child doesn't need to be in the restroom with a younger child at all. No substance abuse or violence in the home. There may be other issues that are identified in the assessment that would need to be included for issues like substance abuse or violence. The child needs to complete their specialized treatment. Going for the assessment and hearing the treatment recommendations but not following through would be concerning. No use of pornography or R-rated movies or phone sex lines. That may mean limiting a child's access to a cell phone where they can access a lot of explicit sexual pictures. They could do sexting where they take pictures of themselves and send them or receive those kinds of pictures. So supervision of all those activities. Or limited or monitored use of the Internet, again, for the same kinds of reasons that you would monitor cell phone use. And eyesight supervision of the child at all times, or certainly at all times when they're exposed to another child. Or if their problem is excessive masturbation, then keeping doors open and watching them closely. The level of contact that this child can have with the victim child or other vulnerable targets needs to be spelled out. Typically, eyesight supervision or no contact. The child who's had the sexual behavior problem should not have any authority over other children. Mom can't say, watch the little ones while I go fix dinner. That child would need to go in the kitchen with her and help her fix dinner, as opposed to leaving them alone with them. Sometimes the contact with the victim isn't allowed, and under what circumstances would that change? A child with a serious sexual behavior problem should not share a bedroom with a younger or more vulnerable child, and the family may need to install alarms, motion detectors, or baby monitors as needed. Moms have to go to the bathroom. Moms have to sleep sometime, and so they can't have eyesight supervision at all times. So those kinds of aids can be helpful. So who should provide this treatment? The therapist needs to be familiar with normal child sexual development, as comfortable working with children as working with adults. The parents are going to need support and information just like the work with the child. And the therapist needs to be able to talk about sexual behaviors with the parents and the child alike. They need to be able to say penis, vagina, masturbation, and in such a way that people who are uncomfortable hearing it can become more comfortable hearing it. The treatment for children with sexual behavior problems, TFCBT, has been an approved treatment, and those the components of TFCBT can be very helpful for these children in learning how to manage their behavior, learning how to control their how to regulate their feelings, address cognitive distortion. Jane Solovsky from Oklahoma, the University of Oklahoma, who worked with Barbara Bonner, has compared TFCBT to the evidence-based treatment that they use, and she indicates that there's certainly more emphasis on safety planning in the treatment with the children with sexual behaviors problems. It is skills-based. It does address distorted beliefs. It emphasizes taking responsibility for concerning behaviors, but the narrative activity is not emphasized. The narrative activity is to address anxiety about having been abused. For some kids who have been abused, that might be a very important component of the treatment, but not for all. And certainly the support and psychoeducation for parents is similar to what you would use in TFCBT. So the parents need lots of support, lots of information. I work as much with the parent as with the child, helping the parents learn to provide developmentally appropriate basic sexual information and basic safety information. That can be very uncomfortable for parents, and so getting them comfortable and then doing dyad work with the parents and the child on that information is an important part of the treatment. Helping the parents with behavior management skills. It should not surprise any of you that lots of these kids have impulsive behavior, they're distractible, they may have aggressive behaviors, and so addressing those behaviors in the treatment. And finally, helping the parents identify and cope with environmental and personal stressors that impact their children. What if mom has an in-home daycare? That may not be the best career for a mom who has a child with a serious sexual behavior problem. Maybe mom doesn't need to be babysitting for her nieces and nephews for a while they get that behavior under control. Personal stressors, divorce, family violence, a parental history of abuse that's been re-stimulated by the child's sexual behavior. All of those are issues that you would work to educate and support the parents on, and it may require referring parents for their own personal therapy in some of those cases. Okay. Here are some resources. The National Center for the Sexual Behavior of Youth is a really helpful website. I used some of the information from the American Academy of Pediatrics, and hopefully all of you know about the NCTSN website and the wonderful resources that are on there. Can we open it up for questions, Chad?
Yeah, I think we go to the next slide.
Okay. Okay, unmute your phone if you've got some questions, or even if you don't, press *6.
And if you want to, remember, you can also type in a question by using that little chat bubble.
This is Leah Wilson. I found most interesting about the report that goes to the prosecutor, but in most of the cases that I work with, the investigation is still ongoing when I get them, so I really have nothing except the word of the parent or the guardian to go on when I do my intake. Any recommendations on how to kind of help with that?
Well, there are two things you can do. One is to call the investigator.
Okay.
And they will usually give you some information. Get a release from the parent and call the investigator. The other is when the investigation is complete, to be sure and get it then, because that can change the picture of what you're dealing with. Sometimes it doesn't, and that's fine. But some of these families some of them are very chaotic, and it's really hard to get good information about what happened. So good question. Any other questions or comments?
Okay, this last call for questions, and obviously if you have any, after this webinar, feel free to email me and I can pass those along to Dr. Worley. I just want to thank you all to, taking time out of your Friday to join us, and have a great weekend. Our April webinar is still in the works, so just be looking for an email on information about that.
Hey, Chad, I do have one question. This is Carrie from Springdale. The behavioral assessment, those assessments that you gave, Dr. Worley, how much are they?
Oh, the BASC?
Yeah.
I'll have to get that information for you, Carrie. We bought the big package so that we have the software, and so
okay.
it was a big cost up front, and then it's we've got the scoring package, and so it doesn't cost us anything after that.
Okay.
Other than the forms.
Okay.
So if you want to follow up with me, I'll be happy to get you that information.
All right. Thank you.
You're welcome. Well, I enjoyed it. I'm sorry I didn't get to see your smiling faces, but you all have a great Easter weekend.
You too.
Thank you.
Thanks.
Thanks.